What's up, everybody? You passed your AEMT. That's awesome. What's next? Good evening there, Danny Tadlock. Hello there, Brian. Nexus Paramedic. Hey, the bossy paramedic girl. Were you coming in to go live and now you're like, damn it, EMS Avenger is live. I never go live if I see you live. I like to support my fellow creators and not siphon viewers away from them if they're live. Oh, you actually work? I thought all you did was go live and raise babies. I know you're in Louisiana. Are you working in a rural area or in like more of a metropolitan area? I've worked both rural and metropolitan, and they are equally as interesting to me. Quick question, CCP or FPC? It's the next step for my career that I want to do. Do you want to fly or do you want to be on the ground? If you want to fly, get your FPC. If you want to be on the ground, get your CCP. However, FPC is going to cover you on the ground. It's everything that CCPC is, or CCP-C, except gas laws as well. And gas laws are easy. There is nothing to gas laws and a little bit of flight stuff. It's not much more than what you would see on the CCP-C. However, from what I understand, the CCP-C is a lot harder. And I think, from what I heard, the reasoning for that is that they believe that a lot of people who will be on ground will often be the sole critical care provider on that unit. And so they are increasing the burden on their testing process. I looked into the impact EMS for critical care now that I became a medic. Do you think I should do it? Absolutely. You need to strike while the iron's hot. If you're in learning mode, then stay in learning mode. No, just get right into it, dude. You know the fundamentals. What you don't know are the subtleties. So go ahead and jump right in there. What are we getting into tonight? I've seen you posting a bunch of vids on calcium and epi, or cardiac arrest and epi. I don't know what I'm getting into. The epi thing, a lot of people want to talk about that. I'm kind of ready to move on and do some other content. I don't know what I want to talk about. In fact, I was just telling my girlfriend this morning that I was struggling a little bit over the last couple of days because it's almost like, you know what, I'm done. I guess I'm done. I don't know what else to talk about. I think the second week of August, I might take a couple of weeks off just to regroup and recharge my batteries, a couple weeks off from social media, and allow myself to kind of get enthused for some new content. Nice beard, Bali. Well, I work for a hospital system, and they don't give a shit if I have a beard, so. Grady EMS here will let you have a beard. You can have a good beard working for Grady. I want to do, I know a video that I want to do is breaking down AV blocks. I want to do a video on just the bundle branch blocks and hemi blocks and bifascicular blocks and all that sort of stuff. I want to do a video on sinoatrial nodal blocks. I haven't had any videos recently that I actually got really creative on. It's just kind of be me sitting there talking. I miss a little bit of messing around with the editing and doing something a little bit more creative, and I want to do that too. I've got some other stuff that's eating away at my time. I recorded my first podcast on Thursday. My first podcast on Thursday. Almost done editing it, and that will be posted on Monday, just on YouTube. What do you think about beta blocker, i.e. metoprolol, on persisting VFib arrest? No quality data on that. However, there's a large trial underway for esmolol, which is a beta blocker for refractory VFib, which is what you're referring to. The pilot study was not very promising, but we'll see what happens with this major study. You're thinking about going in depth on STEMI mimics. I like that. LVH, left bundle branch block, pericarditis. What else we got? Hyperkalemia, benign early repolarization. I broke my glasses today. Haven't seen an update on my daughter. Oh, my daughter had made a full recovery. She's doing fantastic. Thank you very much for asking. Modified scarbosa and its validity. Well, modified scarbosa is valid enough that the American College, the American College of Cardiology, whoever sets the definitions for STEMI, officially made it a STEMI equivalent. So modified scarbosa is very valid. Oh, you're talking about specifically like modifying the one finding, like Smith's modification. That's all you should use. The other criteria was prone to false positives. What do I think about lactated ringers versus normal saline for DKA? So it's a really, really good question. The amount of chloride in normal saline is higher than in the blood. And so that creates a strong ion difference and induces hyperchloremic acidosis. The pH of normal saline, I think, is 5.5. Or is it 4? No, I think it's 4.4. It's 4.4. And no, maybe it's 5.5. I can't remember. And then I think lactated ringers is 6.5, somewhere around there. But normal saline can induce hyperchloremic acidosis, which can in turn, obviously exacerbate the metabolic state, the metabolic acidotic state that a person who's in DKA is in. The data that we have on it is that it's not killing anyone, giving them DKA, but it is complicating management and it's prolonging the amount of time it takes to treat people with DKA. I don't like the benchmark of "but did you die" when it comes to management. Can you imagine how uncomfortable it is to be in a state of metabolic acidosis? Think of any severe DKA patient that you've seen, breathing 40 times a minute. They're dehydrated, their skin turgor is poor, the abdominal pain, the nausea, everything. Why would you want to prolong that by giving them normal saline? They need lactated ringers, not normal saline. Early repol got me one time. Yeah, the thing about early repol is that it doesn't reciprocate. So, and you can look for that little fish hook in there too, that notch in the J-point. How do you feel about EMTs being able to place King Airways? I'm all for it. I think basics, EMTs should be able to place iGels and Kings. iGels, I would prefer iGels though, because it's just, you just place it and that's it. There's no inflating or anything like that. You use the mnemonic elevate. I can't with a mnemonic that's long. Yeah, lactated ringers is better for DKA, for sure. How do you feel about carrying whole blood versus TXA in the field? Well, that's kind of, there's no paradigm in place where you're forced to choose between whole blood and tranexamic acid. I mean, TXA is cheap. It doesn't cost a lot of money. So if you're going to carry whole blood, carry TXA. But at the very least, carry TXA. But I think people are really caught up in TXA right now. And I think the momentum for TXA is exceeding the evidence for TXA. There's not a lot of strong evidence that TXA is doing anything in the field. There really isn't. But as Andrew Fisher, the very famous damage control resuscitationist, says, it doesn't hurt and the price is right. But if you're not working on controlling the source of the bleeding, then, the TXA isn't going to do anything for you. I have been told that lactated ringer increases blood glucose levels in DKA. So what? So what? It's not by much, but so what? We are not trying to lower the blood sugar in DKA. We're not trying to lower the blood sugar in DKA. We are but we are stopping ketone production is what we're doing by moving glucose in the cells so they'll utilize that glucose. It's not about lowering the blood glucose. It's about eliminating ketone production. So if we get a little bump in blood glucose levels, it doesn't matter because that's not what's hurting the patient. It's that ketone production. So if you give somebody a little lactated ringers and it bumps the blood sugar, it doesn't matter in the long term or even in the short term. But the data out there doesn't demonstrate that there is any meaningful increase in blood glucose levels when you use lactated ringers. So go for the lactated ringers. I helped you through EMT school. Thank you. You are very welcome, and thank you for telling me that. And what in the world is Kentuckiana Safety Solutions? I recognize the name. There's certain names that I always recognize that comment. Some of them just because they comment all the time. Some of them because their names are very unique. Like there's a guy whose name is Shitty Mike. It's my favorite name that responds to me. But yours, Kentuckiana Safety Solutions, I recognize just because it's, such a technical name. I'm an EMT and have been placing SGA since day one. There's no reason not to. There you go. How about Colorado EMT IV authorization? I'm all for it. As long as you're doing it and then there's a therapy coming afterwards. Like if you're able to establish an IV, let's say somebody's out there in the middle of August that collapsed on the Colorado Trail, and they're in some sort of heat-related emergency. If you can show up and give them an IV and fluid, that's great. If all you can do is start an IV and you can't do anything with it, then what's the point? It's a debate with our medical director why we don't carry whole blood. Yeah, there's a lot of people that need to be swayed. I think New Orleans has done a lot to start to convince people on the utility of carrying whole blood and defeating the argument that, if you have short transport times or work in a metropolitan area, that it doesn't provide much benefit. New Orleans is a major metropolitan area, and they are saving lives with whole blood in the field. Are you missing part of your glasses? I am. I took them off today, and the thing just fell off. I can see just fine without them. I just can't read without them. But I'm picking up a new pair tomorrow. I'm picking up the same type of frame, but just getting the lens replaced in them. You want to close the NIM gap. That's right. Lactated ringers over normal saline for DKA to avoid that fluid shift. Yep. Hey, EMS Avenger, you're awesome. Well, thank you. The man, the myth, the knowledge, legend. First shift call, SVT masking a STEMI. That's interesting. Always take care of the rate, too, before anything else, because you can have rate-dependent elevation. So, if you have somebody in an SVT and it looks like they have ST elevation, you take care of the rate first. How many people have I beaten up? That's an interesting question. I'm trying to think. I haven't, as an adult, ever had a fist fight, but like in school, maybe twice got into a fist fight. I can remember being like 11 or 12, and there was a kid on the school bus who drove me crazy. He was just one of those people that just ran his mouth all the time, and I suddenly became his favorite person to run his mouth at. And I don't like confrontation, so I tend to just ignore people who are like just trying to get negative attention from me. But I'd had enough, and I just clocked him. Just cleaned his clock, man. I got in a lot of trouble for that, too. I'm about to do the FPC test. Always love your vids, even if I don't always agree with your takes. I don't want anyone to always agree with my takes. I don't want that. I don't always agree with anyone else's takes. It's such a curious thing to say, too. I don't always agree with your takes. You don't want to agree with everyone's takes, because no one's perfect. No one is getting it right all of the time. And what we should be doing is engaging in respectful dialogue. And that transcends medicine. That should go for politics, too. I can remember people... I hear people constantly wanting to offer praise to someone of the opposite political persuasion and say, I don't always agree with what so-and-so says. You don't need to say that. You can just be complimentary of a person and accept the fact that no one is going to line up lockstep with another person. But getting back to the medical part of it, I don't want anyone to agree with me 100%. And I would love any time of the day for somebody to correct me. Because it's great to be wrong, because that means you are now in possession of better information. I want, at the very least, for people to challenge me. Do you know how much I've learned from people challenging me on this app? So thank you for the compliment, and I don't expect you to agree with me all the time. Do you think it's worth to be an EMT for pre-med? I know a lot of people who have gotten into EMS for that reason, and I think that they found a benefit from them. Do you prefer using the stopcock method or the 20 milliliter syringe method for administration of adenosine? So, for those that are unaware, traditionally what we've done with adenosine is that we've taken our adenosine, we push it into a peripheral IV that's as close to the heart we can get, so the AC or even like an upper arm IV. And we'll have a 3-way stopcock on there, so you attach your adenosine to one side of the stopcock and your 10 or 20 milliliter flush to the other side, and you push your adenosine, you switch the stopcock, and then you push your flush. Or you kind of do that clumsy method where you attach your adenosine, push, remove it, and then attach the flush and push. Well, there's been observational studies out there where they just dilute the adenosine into a 20 milliliter flush and just push that single flush. And it is at least as effective as pushing adenosine with a flush behind it, however you push that flush, if not more effective. What I want to tell you is that I am aware of someone who for quite a while may have gotten a little bit confused and believed that you could dilute it in a 10 milliliter flush instead of a 20 milliliter flush, and just push the 10 milliliter flush as a single push. And that person has a 100% conversion rate doing it that way. So I do the single flush method. Should epi become the norm for bradycardia versus atropine? Well, the thing is that bradycardia is not a monolithic event. And what I mean by that is a lot of things can cause bradycardia. You could have an AV block that's causing bradycardia and your ventricles are only pacing at a ventricular rate. You could have AV block related to hypocalcemia. You could have AV block did I say AV block? You could have bradycardia related to hypocalcemia. You could have bradycardia secondary to some sort of conduction disturbance. You could have bradycardia from some sort of toxicity. You could have bradycardia from vagal stimulation. And so the question is, what is causing the bradycardia? Atropine is the exact right fix for bradycardia secondary to increased, for increased vasovagal stimulation. Epinephrine is the exact right fix for another form of bradycardia. So it really depends on what's causing the bradycardia. Use anything but dopamine. Damn right. Frickin' dopamine. Any tips for someone halfway through their internship? Well, I don't know. How's your internship going? Well, I will give you a tip. You just attempt to run as many calls as possible. When I say run them, I mean tech them. That's in Georgia. That's how they say it. For when you're in charge of the call, you tech the call. That's at least in 911. In critical care, we call it charting the call. But attempt to be the one running the call as much as possible. That gives you the most beneficial amount of experience. And anything that you're scared of, you want to embrace with everything. I don't want to run the call because I'm afraid of this. I don't want to call because I'm afraid of that. Well, that's exactly why you need to run the call. You need to run the call because you're ill-equipped to run calls. You need to run the call because you're scared to run the call. You need to run the call because there's a whole bunch of things that you're not thinking about when you have to run a call. All of these reasons are the reasons why in your internship you need to be running calls. I am relatively new to neonatal and pediatric critical care, and I insist on charting calls. It is not very common for the paramedics to be doing this in our system, but I do it because it gives me an incredibly valuable amount of experience in keeping track of everything. It can be very easy when you are not running or charting a call to be focused on the technical aspect of things, starting IVs, hanging drips, pushing medications, setting up airway, all that sort of stuff, but you're not thinking about the entire clinical picture. And so when you're thinking about the entire clinical picture, it forces you to push your critical thinking into overdrive. And so that is invaluable to run calls as much as possible. Is the epi that's in dental lidocaine enough to treat anaphylaxis? It is not. It's enough to cause vasoconstriction to the immediate area around it. That concentration is 1 to 100,000. I have my 6th attempt for Medic on Wednesday. I've got the content, just struggling with the National Registry. Tips, yes, follow the bossy paramedic girl, because she kind of owns this space right now on EMS Talk, is on test taking. So, and she has a playlist of all that sort of stuff. So she is the person that I would refer you to. Also, because there's been such a drastic change in the way the registry tests, I'm a little ill-prepared to advise people how to prepare for that. But going into it, don't cram the day or two before you take that test. Get a good night's sleep, eat well, exercise, stay away from alcohol, and keep that mind fresh and rested. I'm nervous, but thinking about going to medic school. My medics say I should just do it. You should just do it. What are you thinking about? I mean, what's the holdup? If you're thinking to do it, do it. The only thing to be scared of is whether or not you're going to commit to it. But if you're going to commit to it and you're going to do the work, you're going to do fine. I mean, unless you just don't have the aptitude for it. But I would hope that you have people that care enough around you to tell you, hey, I get the sense maybe you're not ready for this. But if you're going to do the work, then do it. but you have to do the work. But if you're going to study, if you're going to take advantage of the time that you have to study, you're going to do the reading, you're going to get together with people, you're going to make up your flashcards and all that sort of stuff, then there's nothing to be scared of. The cure for being scared in medic school is to do the work. I hope I can be half as smart as you when I get to the same point as you are in your career. I hope I can become half as smart as people think I am at this point in my career. There's Mike. Man, I've been live for 10 minutes, man. Where you been? How long does it take to go from a study to we changed X protocol? A long time, unless it was like a really, really major thing. I'm trying to think of the last thing I saw where there was a major shift because of a study that just came up with a no-nonsense conclusion. Mike could tell me, Mike Verkest, who is with ESO and also has done some stuff with FlightBridge. I think your name is behind the PART trial, wasn't it? Weren't you involved in the PART trial? Or am I thinking of something else? But there was a couple of studies recently, 2018. Yep, Mike was involved in the PART trial, which was the U.S. trial comparing survival rates in cardiac arrest between people who were intubated and who used a King airway device. Survival rates were higher with the King airway device. And there was an accompanying study in the UK, the Airways 2 trial, where they compared survival rates between the endotracheal tube and the iGel. That was a wash, but their first pass success rates were way higher than the US. But a lot of people in the U.S. made a very, very quick change. A lot of services made a very quick change to just saying, you know what, just lead with the iGel or the King or whatever it is you have. But most other times, I just send an invitation to somebody for something and I have no idea who I sent it to or what it was. But I just saw it flash on my screen. I think I accidentally swiped my screen and invited somebody to do something. So whoever I did, I probably invited somebody to go live. Please do not accept that. It's just going to be weird. Even when you think about the Paramedic 2 trial, which was years ago, that demonstrated that neurologically intact survival was lower with the administration of epinephrine, there's some people that made some changes, but there weren't wholesale changes to U.S. protocols on that. And that's because even with strong data, you want to repeat that data. So for us, it was TXA. Crash 2 was pretty convincing to our medical directors, but it was 5 years. Yeah. I was just talking before that I feel like the enthusiasm for TXA is stronger than the evidence for TXA. Not that there's no evidence for TXA, but just there are a lot of people that have hard on for TXA that maybe really don't understand the value of TXA and what's required to allow TXA to actually exert a benefit. Starting my first EMT job on Monday. That's awesome, man. Congratulations. If I can give you some advice, stay away from the complainers and from the people who engage in dark humor. Just stay away from it. You don't need dark humor to help you cope. And it only sets you up for a really, really bad moment. You have a ton of data with outcomes rolling in. I hope that data is with the 2 milligram administration, because that's what a lot of people are moving to. For those of you who are watching, I will be releasing the first episode of my podcast on Monday, EMS Avenger 20 Minutes to Save the World. This is going to be interviewing Nick Nudell, who is the president of the he's the president of the American the American Paramedic Association, and he is behind the effort to launch the American College. I'm getting all the names mixed up. The American College of Paramedics. And we're going to talk about this big launch that they had, about changing the name of everyone to paramedic and then having, the APA. But he's also behind the launch of the American College of Paramedics that wants to oversee kind of bringing EMS into the 21st century, calling everyone paramedics, kind of modeling what we see in Canada and in the UK and in Australia. So that'll come out on YouTube sometime on Monday. This is going to be my first episode. There was stuff to learn there. I'm not a master editor or anything like that. So I hope things will obviously improve as we go along. This is kind of a soft launch of the podcast, so we'll see. And for now, it's just going to be YouTube. Going to wait till I get a bunch of episodes on my belt and really get better at doing it before, I start extracting the audio out and launching it on Apple Podcasts and Spotify and all that stuff. Thank you, Jero V GPS MV, for the follow. And I was pretty tough with them. There's a lot of things that people want to know about this proposed change. And I keep messing with my glasses because I broke my glasses today. In fact, I'm just going to take them off for a minute. I can, if I'm far enough away from the phone, I can pretty much keep up. But I was I don't want to say tough with them, but I asked them all the questions that people asked me about it. Hello there. Just want to say thank you for all that you do and to the info you share. Thank you very much. I appreciate that. I'm interested, but I'm skeptical about the ACP personally. I don't blame you. I am neither optimistic nor skeptical. It is right now only a thing that is being discussed and not a reality. I will say that what his desire is to make it an organization that is by paramedics, of paramedics, for paramedics, and he allows for the fact that paramedics may steer it in a different direction than he wants it. He's left his ego, or those behind it have left their ego out of it entirely. So what they want is for all paramedics to have a voice together that can be amplified by an organization like that and work together to advance the field. So he essentially conceded that, paramedics may not want this or they may not want that, so they may not steer it in that direction. So he was a very humble individual. There's no real momentum behind this effort, in my opinion. I think I probably agree with you. I mean, they don't even have a website, which I found a little weird. Like, you can join the APA and kind of get behind the effort there, but you would think if you were going to, GEMS was kind of pushing them really hard, and you'd think if you were going to launch something like that, that you would have an accompanying website where people could get right to exactly what you're talking about and get some support behind it or whatever, but there's nothing like that. And I asked him about that. He said they're working on it. I like the concept of calling everyone paramedics. To the people who think that creates confusion, I don't think it does. I don't think that most people in the U.S. have any concept of the difference between EMTs and paramedics. I think that there's no confusion to be had there. It's really just the only challenges there are just people who are kind of like veterans in the field who don't want their uniqueness taken away from them. The reality is EMSers can't agree on what color the sky is. It's fireman red, isn't it? Would you be interested in having a conversation about chronic diseases and the treatment in emergency medicine? I mean, that's what I do every day. Not necessarily chronic diseases, but I don't know what that conversation looks like. Like, are you I don't. You would have to tell me more about that. What do you think about the people who are responding by getting territorial? I just say get wrecked. Change, scaring people since forever. Honestly, I think that any provider that works in cooperation with a physician instead of being a provider in their own right should be called a medic. So that includes an EMT, that includes an AEMT, that includes a paramedic, that includes a flight paramedic, that includes a ground paramedic, includes a CRN, it includes an LPN, it includes a nurse. All of them should just be called medics. And you have medics that have specialties. So you are a pre-hospital medic if you're working on an ambulance or out there in the field somewhere as a community paramedic. You are a bedside medic if you are working, or a clinical medic if you are working in like a doctor's office or a hospital. You call it a clinical medic or a bedside medic. You see where I'm going with that. I just think you should just call it medic across the board and then just specialize it. The thing I'm most interested in is push for treat in place. Me too. I think that is the thing. That is the Bugs Bunny wearing the lipstick and the dress that's standing in the corner going. That's the thing in EMS that we need to be doing right now. Absolutely. To me, you earned the privileges and responsibility more so than the title. Yeah, we can't be looking at the title as something that is this prestige prize that we earned. I mean, be proud of the work that you've done. Be proud of where you've come from and where you are, but don't get attached to the name. And the name means what we say it means. Talking about the treatment or lack of treatment. I don't know what you're talking about with CD. With lupus, sickle cell, etc., patients get in the ER or pre-hospital. I mean, I don't know, when you say, would I be interested in talking about that, like if you're wanting to ask questions here, sure. If you're saying you want to be on the podcast with me, I don't know who you are. I don't want to be rude, but I mean, you could send me an email to Jimmy at EMS Avenger and tell me what's on your mind. My service did it for a while, but the physicians who were supposed to clear patients, are you saying they were not cooperating? Because that's what I found to be the case, is that physicians are like, yeah, and then a medic calls them and they're like, oh shit. What if it's this? What if it's that? What if it's this? What if it's that? And then, they get out the liability dildo and, shove it up the medic's ass and make them transport. As a new paramedic for about 3 months, how do I get rid of these feelings of imposter syndrome? I will let you know when I figure that out, because I have been a paramedic for 20 years. And I wake up every morning thinking that people are just suddenly going to like figure out that I'm full of shit. Seriously. I just, even as I see my success on social media, I still think that people are just going to be like, this guy's just full of shit. He's so fake and so full of crap, and he doesn't know anything. He doesn't know what he's talking about. He doesn't know what he thinks he's talking about. I feel like my coworkers behind my back are saying that he doesn't know anything. I think that my bosses behind my back are saying, I mean, you know, he pushes 10, but he doesn't know nearly as much as he thinks he does. I'm literally motivated by the fear that I don't know what I should know. So all I can say is just embrace that fear and do the work to try to reassure yourself that you're doing good work. That's all I can say. The hell did you just say? Start transport before you even start compressions. You want me to block you? I saw you go to Crash and Learn. I did, and I'm going there in a couple of weeks. Dan from Heavy Lies the Helmet. Dan Rua? Dan from Heavy Lies the Helmet is my operational medical director. That guy is so freaking smart, man. I had a sinus infection patient, and the physician was like, could be new onset of diverticulitis. Yeah, I know. The thing is, though, is that sinus infection patient, when he goes to the hospital, is he sending them for an abdominal CT? I mean, really? Is that what's going to be ordered at the hospital? If you're telling me that's going to happen with anyone of signs or symptoms of a sinus infection, that they have to get a CT rule out first, then okay, sure. But is that really what's happening? I'm hoping to get some content with Dan this time around too. Last year when I went to Crash and Learn, there was a lot of people there, a lot of the creators there and the hosts there who had no idea who I was or what I did. And that's because my appeal is a little bit more kind of, and this is purposeful, is for people who are more in the beginning of their EMS journey, or people who just didn't really know that there was this whole world of medicine that they could just literally reach out and grab. But in the people who are operating at a really high level in critical care and that sort of stuff, they're not on TikTok watching what I'm doing, right? So a lot of people didn't quite get it. And so I was trying to talk to Dan about creating some content, and I don't really think he quite got it. This year, I'm actually partnered with Heavy Lies the Helmet. I'm doing promotional stuff for them, creating videos that's giving them some exposure. I'll create videos from the conference and after the conference. And so this time they understand what my role is, and they know that they need to be creating content with me when I get there. What's your thoughts on taking pediatric trauma alerts to level 2 that only take adults? Like, I hate how people justify bringing children to adult hospitals. It's just because trauma, you know? Or they'll say something like, well, at least they can stabilize them there before they send them out. You fucking stabilize them. That's what you went to paramedic school for, to stabilize these patients. You fucking stabilize them. Now, have you identified something that the emergency room can specifically do at an adult trauma center that you can't do and has to be done right now, and literally seconds are on the line? Okay, fair enough. But otherwise, you know, if we're talking 10 minutes or whatever, I mean, get them to that pediatric center. I cannot tell you how many times me and my crews are just like slamming our heads on a desk because someone decided to take a detour to an adult trauma center instead of going to the pediatric trauma center. Hello, Mr. Avenger. Thanks for what you put out here. I have been saying some of this for a while. You're welcome. Speaking of heavy lies the helmet, I wonder how Brian's doing. Oof. Yeah. I don't want to say anything on TikTok about that. Any thoughts on NMETC Medic School out of Boston? I don't know what that is. Level 2 is fine, bruh. Better than, I don't know what better than done actually means, but you're just saying words right now. I am literally in neonatal and pediatric critical care, and I can tell you that you need to take your pediatric trauma to specialized pediatric trauma centers if they are available. The thing fell off my glasses today. I literally just kind of went like this, and the piece was just still sitting here when I took my glasses off. So yeah, I'm just trying to get through the day with this one pair I have right now. Great content. Critical low paramedics in my region. Local services pushing AEMT. Thoughts? I mean, most 911 calls can be run by AEMTs. If you're critically low in paramedics, then you need to put them in fly cars and dispatch AEMTs to these calls, and they can call for a medic if they need one. Why would you take a pedicure to adults? Because sometimes adults need pedicures. Like, if you have, a ped with a hot belly who, that's such an old school term. If you have a ped, that was ejected, let's just say flight's not available. If you had a ped that was ejected, they've got a distended abdomen, indications that they're bleeding internally. You don't carry whole blood. You've given them 30 milliliters per kilogram of isotonic fluid. They basically have gotten more hypotensive and their blood has turned pink, and you just have given them everything. You've thrown everything at them, and you're going to pass an adult trauma center. I mean, obviously, you go to the adult trauma center, but it's dependent on where your pediatric center is and what the condition of your patient is. But don't come up with bullshit reasons to go to the adult trauma center, I guess is what I'm saying. And most people come up with bullshit reasons not to take kids to pediatric centers, even in the absence of trauma. I see it all the time. And this is the most common thing they say. The parents insisted. No, they didn't. The parents did not insist that. You just didn't sell it. Thoughts on amio versus lido for refractory ventricular fibrillation. The data is, I don't want to say inconclusive, but the data for amio and lidocaine is just barely on the side of beneficial. And the dial moves just a little bit more towards amio in the field. But it's not strong data. It's not powerful data by any means. Do I do public speaking in conferences? I do. I get invited to stuff all the time. And I love doing it. And sometimes I get invited to come to like a service and just like speak like informally, like do like an in-service, like on cardiac arrest or something like that. Somebody's name is Pork Egg Roll, and that just made me immediately want Chinese food. What are your thoughts on IO versus IV for the first line access and codes? I think that generally speaking, that you are going to get the medication into central circulation from your time. Let me back up. From the time of your arrival to the time of the first delivery of medication to central circulation is going to be faster with an IO, right? So why would you not just go ahead and drill? And if you can get a humeral head IO, or even better yet now, distal femur, which is just about as fast as humeral head, why are you screwing around with an IV? I mean, I can appreciate after the fact if you have the personnel establishing an IV line, but if you're getting there, just drill, baby, drill. Let's get moving here. Now, the only caveat I'm going to add to that is that we haven't had a properly constructed study to look at this. We basically have studies that have looked at survival rates when comparing IV to IO as a first-line access, and survival has favored the IV cohort, but we really believe that one of the reasons for that is because sicker patients are the ones who are getting the IOs because they're just not presenting with proper venous presentation because of how sick they are. And so they're just more likely to die and more likely to need an IO. So we haven't had a proper RCT. I do know that there is one happening in the UK right now. I cannot remember for the life of me what it's called. I think it's the Alaris. I think that was the name. Something like that. So that's going to be a very informative study. Also, there's some question about amiodarone and lidocaine being lipophilic. Lipophilic means that the medication, that fat really likes that medication and it will absorb that medication and not let it go. So there's some question as to whether when we are administering amio and lidocaine through an IO, whether as much of it as we want is getting to central circulation. Ever met Joe Mistovich? That name sounds familiar, but I'm not sure why I would know it. You should look into AAENP's national conference in Dallas. We would love for you to present. All you gotta do is send me an invite. I don't apply for conferences. I'm not interested in the pressure of like applying for conferences. So if you send me an invitation, I would be happy to submit at that point. I'd be happy to talk with you about what I could do at your conference, but I don't like apply to conferences. New Medicare, just starting off, any tips or advice? Never stop learning. Associate yourself with positive people who engage in good behavior. Oh, TikTok wants me to solve the puzzle. TikTok can't tell, even though I'm sitting here talking, that there's a live person here talking. And so every once in a while I have to solve a puzzle. Bossy, do you have to do that? What was the question? Oh, tips. Associate yourself with the best examples that you can find and stay far, far away from the worst examples that you can find. Make friends with nurses, make friends with doctors, make friends with firefighters. Do nothing but make friends. Build a consensus of people that want the best thing for those patients, and take advantage of any learning opportunity that you can. Oh my God. Al Secor, talk about a survivor. I don't know if you're in my live. I see that you're on TikTok, but talk about a cardiac arrest survivor. Man, that man has been through it. As much as I love Chick-fil-A, they have the worst drinks. You know how McDonald's has like the best drinks? Because they actually have like a contract with Coca-Cola that they have like all the best equipment, and they have metal pipes carrying all that syrup and stuff to their machines. And so you just have this amazing tasting drinks that come from McDonald's. Chick-fil-A has the worst drinks. They have some really good food, but their drinks suck because they use that because they have the worst ice probably. I know, Logan, right? Yeah. What a recovery that guy has had. And what a testament to American medicine and the dedication that people who work in the American healthcare system have for getting people better. I mean, for anyone who's out there disparaging the American healthcare system, saying that they're beholden to big pharma or that they're, pushing vaccines on people or whatever it is that they're doing so they can line their own pockets and they don't give a shit about people. I see people like Al and the people who are saying all this bullshit, I say fuck you, because what we go through and the blood, sweat, and tears that we go through and the amount of money and resources that we use to save one person that's unknown to anybody else in the system. You are person A who has suffered a cardiac arrest, and a year later, due to the blood, sweat, and tears and dedication of an amazing healthcare system around you, you are enjoying a second chance at life. So get wrecked if you think opposite. I was thinking about this the other day. A couple months ago, we responded to an urgent care for a kid that was diagnosed with flu. And we get there, and this kid just looks sick. Like, man, he looked so sick. He's just kind of laying on the exam table in there, and he's lethargic. And the first thing we do when we walk in there is we're thinking, is this kid sick or not sick? And he was sick. And he had muffled heart tones and barely palpable pulses. He was hypotensive despite having received 30 milliliters per kilogram of fluid. I mean, this kid was just sick. And like the next day, he had to be flown from one of our pediatric systems to the other pediatric system because he had to get put on ECMO. And everything that we went through for that kid, I mean, I was just thinking about the resources, and it was just incredible what had to happen to get that kid better. Just absolutely mind-blowing. Is there a trick to improve in listening to muffled heart tones? I don't really see any medics do it. I don't think a lot of medics think about heart tones. In pediatrics, we listen to heart tones all the time, but muffled heart tones are exactly that, and you know it when you hear it. I mean, you should hear somebody's heartbeat when you put a stethoscope on someone, right? So it's not about a trick to listening to muffled heart tones. It's about listening for muffled heart tones, meaning you're actively thinking about it. If you're thinking about heart tones from one patient to the next, you'll know when you don't hear them very well. You're like, man, I can barely hear it. I heard somebody say in a conference the other day that was bullshit, that, casting dispersions on who can hear muffled heart tones. Everyone can. Everyone can hear muffled heart tones or not hear them, as it were. You just have to be purposeful about actually listening for them. My son is sending me a flurry of messages. I'm assuming it's because he got a huge information dump from That's why. He's been keeping up with Comic-Con, and it's been announced that Robert Downey Jr. will be playing Doctor Doom in the new Avengers movies, which is called Doomsday. How about that? Hate to say it, but I don't listen to them almost ever, and I don't know any medics here who do. Shame, shame, shame. Your stethoscope should be on you at every call. You should listen to breath sounds and heart tones on almost every patient. Now, if your patient has a sprained ankle, you don't necessarily need to listen to breath sounds and heart tones. But, any patient that has any sort of complaint from the groin to the trachea, you should be listening to breath sounds and heart tones. That's right. Listen to heart and lung sounds on every patient. I did see the new Deadpool movie. It was awesome. Should more states adopt delegated practice, or are states' scopes the way to go? What I think is that there should be a nationalized paramedic practice with delegated practice. So there should be a set standard that we set on a national level. Like, this is the minimum, this is what everyone should be able to do. And then states should say, okay, but we need them to do more than this too. That's fine. So I think it should be a combination of a minimum national standard that can also be delegated by states, which is, we kind of have that now, I guess. There's an established national curriculum, but I think that there should be a set scope nationally. We're not cardiologists. Okay. Who's asking you to be the cardiologist? You listen to breath sounds. Are you a pulmonologist? You splint broken extremities. Are you an orthopedist? No. Stop trying to be clever and be a paramedic. When you do a lit search, what is your process? I put in different search terms, and I try to hit the search from a lot of different angles, and I try to avoid my bias. So let's say, like today, I was looking for systematic reviews and meta-analyses on the benefit of bicarb in cardiac arrest. If I was searching to my bias, I would say studies on bicarb harming in cardiac arrest, or something like that, right? And I would get fed studies that met that search criteria. So I search for benefit of bicarb in cardiac arrest, and I search for harm of cardiac and cardiac arrest, that sort of thing. And I try to circle around the subject with as many search parameters as possible and look for the common denominators and how they intersect with each other with different studies. And I look for those studies that they all seem to reference. Those are usually going to be the most powered studies. So that's a good way to search. Hi, sir, a new paramedic here, and I enjoy your educational videos. Thank you so much. I appreciate that. I'm a paramedic student, almost done with medic school. Any tips? What kind of tips are you looking for with, like, what to do when you get into the field, or what? Listen to heart and lungs at least once during detailed assessment. No excuse not to. And the thing is, too, is once you get into the practice of listening to heart tones, the first thing you'll start noticing when you listen to heart tones is either how loud or soft they are. That will be the first thing that you notice, as far as I'm noticing something is not like it was before, right? After that, you'll start noticing different murmurs, like your S3 and your S4 murmurs, and hearing different clicks or thrills, that sort of thing, or whooshes. And those are important. It's important to be able to understand heart murmurs and not absent, but diminished heart tones. That's important because it's going to make a difference. You have somebody with some sort of cardiomyopathy. There are things that you don't want to do with that patient that maybe you would do without having discovered that they have diminished heart tones. So Or it may steer you to doing something you weren't inclined to do before. Say you're in an area where you can perform a pericardiocentesis. So these are important things. You have to remember that paramedic school is EMS for dummies. That's what paramedic school is. And so if you're happy with that, congratulations on your $21 an hour. But if you actually push beyond that and do things like listen to heart tones and listen to breath sounds, and go above and beyond for all of these things, then you're going to eventually be incredibly high-performing personnel. And you're going to have choices on where you work and how much money you make. Even if you can't tell what it is, if you listen enough, you'll be able to tell when things are wrong. Oh, Logan, by the way, congrats on your CFRN, man. That's awesome. What's my take on pericardiocentesis pre-hospital for ALS? I think in traumatic arrest that all systems should allow their medics to do that. It's a no-fail intervention in traumatic arrest. I mean, your service was probably going to call it before. So do bilateral finger thoracostomy, pericardiocentesis, intubation, and volume replacement first. Do all of those things. But I think that there should be a protocol for pericardiocentesis and traumatic arrest for everyone. Well, you got to get POCUS first if you're going to do it in somebody who's not in traumatic arrest. I think that you can have a non-POCUS protocol if it's traumatic arrest. This has been a great live, by the way. I didn't expect on a Saturday night. Well, no, I used to do lives almost every Saturday night, and they were happening. Back when I was in medic school, I had to shadow a respiratory therapist, and they harped on lung sounds. Look, I am in pediatric and neonatal critical care. And, like half of what we do, particularly as we start getting into fall, and like every kid has either, what's the thing that causes bronchiolitis? I'm so embarrassed right now. What's the disease? RSV, DERP. Every kid has RSV or rhinovirus or coronavirus or enterovirus or all three. These kids, their airways are just falling apart and they're not oxygenating and they're, all this sort of stuff. I suddenly had to relearn breath sounds. Like with adults, it's not very complicated listening to breath sounds. I mean, either they're clear or they have rhonchi or they're wheezing or you can hear some rails or whatever. But if you're listening to adult breath sounds regularly, it's not very challenging. It is very challenging with kids. It really is. And I have had to admit repeatedly that I essentially am relearning how to listen to breath sounds with children. And it is so important, not only to listen to breath sounds, but listen to them in multiple regions, to listen to them up here in the neck and the side of the face, particularly in kids. You know what? Kids make so many weird noises when they breathe normally, especially younger kids, especially like little babies. When their head is down and they're breathing, they're kind of like, and you have to listen really well everywhere to rule out whether that noise is coming from in their lungs or whether they're not swallowing very well or because their neck is kinked a little bit from how they're sleeping. And sometimes kids just moan or grunt normally when they're breathing. So listening to lung sounds is so vitally important to what we do when it has to do with the respiratory or airway. Had someone to do an EKG with the sticker in the wrong spot. caught the STEMI an hour later. Yes, lead placement matters. Thoughts on supraglottic airways at the start of the arrest and then moving to an endotracheal tube after access. Why are you moving to an endotracheal tube? Is the SGA working? Then leave it alone. Is epiglottitis where you want to give humidified O2? I don't want to do anything for epiglottitis. For croup, I will give humidified O2. The epiglottitis, I don't see a lot of people giving humidified O2 for epiglottitis. That is one of the very few pathologies in a child where you're like, don't even look at it, you know? Because that's how most medics treat kids as a whole, is don't look at the kids and maybe they'll be fine. That's almost literally the treatment in epiglottitis. But we do that in croup a lot, though, is give them humidified O2. Oh, humidified O2. I thought you were like talking about nebulized saline. You should always humidify O2 with a child if you can. Like if you're putting them on 2 liters and you have what's called a bubbler, you want to do that. Have I thought about becoming a doctor? No. I'm 55 years old, and I don't plan on working in the field past retirement age. I want to go out and live my life, you know. I'm saving this money for a reason, which means that I have about 10 years to go. So by the time I would graduate from a medical school, what? I got 3 or 4 years to practice. No medical school is going to take me on. Also, I really, really love what I do right now. I love it. I'm in love with it. I always have been. Also, I have 3 kids, and I would rather just invest in their future than mine at this point. Very, very easy chance of losing that airway. Really? Is there really an easy chance of losing that airway? That sounds like something that we just say. The SGA to ETT was recommended to me by experienced medics for the purpose of a more secure airway. That's a non sequitur. It is a more secure airway, but you don't necessarily need a more secure airway. If you're working cardiac arrest and you place, let's say, an iGel, and you have the pulse oximeter on the patient, which I hope you do. You should have your pulse oximeter on the patient cardiac arrest. They're setting 95%. You look at your end tidal, you're getting 25 or 30. The patient has, you have no signs of gastric insufflation, and you're getting good chest rise. Your patient has not demonstrated any sort of gagging or anything that would indicate that you have to worry about vomitus or anything like that. That is all you need right there. That's all you need. You don't need to change anything. Because secure airway or because gold standard just isn't a compelling enough reason. I mean, if you guys have like a 90% first pass success rate with endotracheal tubes, then knock yourself out, you know. But if you're dropping SGAs first, there's a reason why you're doing that in the first place. So now, when I say that, and I need to make another video on this because it's so hard to cover all of this in one video, but every patient's different. You can have a patient, excuse me, let's say a 40-year-old who was running a marathon or playing tennis and they dropped dead and they had suffered cardiac arrest on the tennis court. They're not vomiting. They still have a modest respiratory effort because, you know, they just arrested. They got bystander CPR. And they're in VFib as a presenting rhythm. There is a very high probability that you are going to get a rhythm conversion on that and get a pulse. And not only do you not necessarily need to get a tube on that person, you may not even need to drop an SGA in that person. Like, you can ventilate that person just fine with a BVM and a mask. Like, the chances are you're going to get a rhythm version of that person, and he's going to start breathing on his own relatively quickly. Now, you get someone who maybe they're 50 or 60, they have a history of cardiac disease, and they had what you think was probably an MI after a couple of days of chest pain, and their presenting rhythm is PEA. And they didn't get bystander CPR for like 8 to 10 minutes before you got there. Let's say 10 minutes. They had a 10-minute downtime with no CPR. It takes about 10 minutes for your alveoli to collapse, atelectasis, right? And so that means that you need positive pressure and some PEEP to get those lungs open and to keep those alveoli open. And probably the way you want to go with that patient is a more definitive airway. You might want to tube that person, because that's probably you're probably gonna work that one a little bit longer. Might not have a good chance of getting them back, but you're probably going to work them a little bit longer. But you could go either way on that. You could drop an SGA or you could drop a tube, one or the other. But you want an advanced airway on that patient. Now let's say you get a patient who, let's say they have a history of CHF. They've been out of their medication for 2 weeks. They've been developing peripheral edema. They've been starting to cough a lot. And they go into cardiac arrest, and the wife said that he had pink frothy sputum coming out his mouth when he arrested. That patient needs a freaking tube. That patient needs the gold standard of airway management, or somebody that went into respiratory arrest because they had COPD and then went into cardiac arrest. Those people need their airway secured. They need to have a direct path from outside of the mouth into the trachea. So it's all patient dependent. It is not one size fits all. Can medics in the U.S. give TXA and TPA? They can give TXA. They cannot give TPA, but some of them can transport a patient who's on TPA. SGA to ET is a flex, nothing more. Pretty much. If your patient's deteriorating, I can see it. If they are ventilating just fine with that SGA, no reason to change anything. What's your opinion on obtaining associate's bachelor's degrees in EMS? Will it matter for the future? I think in the future it will matter. I think the paradigm will change in the future. If you're going to get it now, you have to ask yourself what you're going to do with that bachelor's. There's 2 states that I'm aware of that require them, so let's just take that off the game board. Or maybe it's associates that they require. I think that they require associates. Are you planning on going to medical school? Are you planning on getting into EMS management or going to nursing school or something like that? I hope you're not sticking with EMS and getting a bachelor's with the plan of going to nursing school. That would be weird. But if you have a plan for what to do with that bachelor's, that's not dependent on EMS changing anytime soon, then yes, you should get that bachelor's. If you have a disposable income and you plan on being in EMS, let's not say disposable, but let's say you plan on being in EMS for the rest of your life, because that's your calling, because your dad did it, and his dad did it, and his mom did it, and you just want to be the most well-rounded provider that you can be, and you can afford it, then yes, get your bachelor's. But if you're thinking that you just need to get it because reasons, then you're just going to go into debt over nothing. Had a patient go into sine wave for the first time during internship. I'm in awe. In case you don't know what sine wave is, that is from somebody who is incredibly hyperkalemic, and the rhythm looks like this. Just an easy slope. What kind of doctor are you? I'm a phrenologist. You had to have seen There was a movie with Charlie Sheen and Emilio Estevez. I can't even remember what the title is now, but there was a running gag about a specialty called a phrenologist. I'm not a doctor, I'm a paramedic. Hello, Shogun of Brooklyn. I'm considering obtaining a master's in critical care paramedicine. Thoughts? I wish I could have a master's in critical care paramedicine. What are you going to do with that? Well, thank you, Tariq. I appreciate that. Then you should do it. You know, it's funny. There's 1,000 EMS providers out there on TikTok with the name Ditch Doc or some variation of Ditch Doc. That's the first living the dream that I've seen. Opinion on esmolol for VFib, for refractory VFib. So esmolol is a beta blocker. Refractory VFib is when in a 10-minute period you have been defibrillated 3 times, you've gotten 3 EPIs, and you've gotten 2 antidysrhythmics like lidocaine or amio, and the patient has remained in VFib. There is no quality data demonstrating benefit for esmolol in refractory VFib. There was a pilot study performed, and it demonstrated no benefit. But the pilot study is not supposed to be a definitive study. It's just essentially to establish that you have everything that you need to conduct, to have a well-conducted larger study. So that study for esmolol is going on right now. It'll be the first quality data that we get on it. Hello, love your videos. Do you know if SpO2 in the forehead is more or less accurate than fingers? I really don't, because in EMS, we never, well, I don't want to say we, I don't want to speak for, I don't know many services that use forehead pulse oximetry. It's really not a thing in the field, so I really don't know. Have you heard anything about the new paramedic NREMT? I mean, I know how it's structured, but I couldn't tell you how people are doing on it. I couldn't tell you how to prepare for it. Can you tell me your approach in managing a patient you suspect has Brash syndrome? No, because I never have had a patient with Brash syndrome. Logan says forehead and ear pulse are pretty accurate. We use it very frequently in Trendit to compare ABGs. But if you were wondering what Brash syndrome was, somebody who, it's like a perfect storm of like renal failure and calcium channel blockers causing just like widespread effects like bradycardia and stuff like that. But I've never had a patient like that. When would I Narcan a patient in my assessment for an overdose scenario? After you begin oxygenating them. You always oxygenate first. Oh yeah, well, specific indications too. They're in respiratory arrest of suspected opioid overdose. Now, sometimes, and really, it should be respiratory arrest for unknown reasons. Like we can't always know why they're in respiratory arrest, but if you can't attribute it to anything else, then Narcan's kind of a no-fail intervention there. But you always oxygenate first. And for everyone out there that has a story about a patient that came up swinging or went into withdrawal symptoms or vomited and all this sort of stuff, if you oxygenate your patient first and and you titrate, I don't want to say titrate, but you don't just like slam home 2 milligrams of Narcan or blast them with 4 milligrams intranasally. If you were to give them like just 0.5 milligrams IM, most likely they would come out of that, breathe on their own, and not have any of those undesirable side effects. Hello, Shane. How you doing, man? Long time no see. Thank you for the follow, Daniel. Hello, Eli, with the cool hat. I was sitting here thinking about my description for Brass syndrome, and I didn't like the way it described it. Brass syndrome, essentially, you're taking AV nodal blockers for any number of reasons, and it just kind of wreaks havoc on your kidneys, and you end up developing like severe potassium issues. But like I said, I've never had to treat it, so I don't really know how to speak to it. But you can end up with hemodynamic issues, severe hyperkalemia, and that sort of thing. The change has been great. The change has been fantastic. And Shane is referring to me switching from one company to another. Something that I've had to, I was actually going to make a video on this too. Something that I've had to process and acknowledge to myself. I said to myself for a long time that I was not burned out doing 911, that I was very happy, but that I was just kind of looking to take the next step. I realize now, in looking back, that I was incredibly burnt out. And the way it exhibited itself was in that I could not tolerate working with anyone other than someone I specifically wanted to work with. I had gotten myself to a point where I had to handpick a partner and work with them. And I didn't even realize that I was doing it. And if I didn't want to work with you, then I was miserable. And I realize after the fact now that that was a sign of burnout, because I needed to have somebody who could stabilize me sitting next to me. It's weird coming to terms with seeing that you are carrying some sort of trauma around, and that you're not even aware of it, and it's exhibiting itself in a very specific way. Ventilation and oxygenation to achieve normal EtCO2 and SpO2 prior to Narcan seems to lessen issues. Exactly. Do you do peds and neonate critical care transport? I do, full time. In fact, there's somebody that I owe a very specific apology to because of that. Now, there are personalities out there that only ever get along with a select few people. I haven't traditionally been like that. I've always been able to get along with everyone. Now, there's people that don't necessarily get along with me because I'm a very specific personality. But I noticed, but I think in the last year where I was working, that I had gotten to the point where I could only work with specific people. And, shaking it up and moving on to somewhere where I'm getting challenged and working in an environment where the workload itself is not burning us out, man, it's so nice suddenly, having all new personalities to work with and learning new people and that sort of thing. It's really refreshing. Providing BBM ventilation prior to giving Narcan is the AHA algorithm. You are correct, sir. We got a lull here. What's going on, folks? What else we got? Doing peds and neonatal critical care transport is my dream job. I didn't realize that it was going to be my dream job, but I freaking love it. I really do. Kids are not hard. They're not hard to take care of. Well, I love you too, Logs G269. And kids are easy to take care of. The only reason why they're difficult is because we just haven't educated ourselves enough about them. Adults are just as complicated as pediatrics, if not more, because adults are starting to break down left and right. Pediatrics are fairly rugged individuals, and they're fairly predictable as far as what to look for as far as crashing goes, because they compensate for everything with heart rate. And the thing about kids is that there's no guile within them whatsoever. Like, they didn't call 911 to get a ride across town. They didn't call 911 to get a meal at the hospital. They didn't call 911 for the 17th time in a week. They don't want to be sick. And they're innocent. They're easy to have compassion for. Now, I have compassion for adults too. And I am particularly, I consider it kind of like my highest calling to have compassion for adults that are hard to have compassion for. But it certainly is easy to have it for children. Chelsea has been taking care of a 23-weeker. Y'all can keep the tiny ones. You have a COPD patient. They suffer a TBI with herniation. What is your ETCO2 target? Well, the EPIC trial told us that there is a high association between increased mortality and allowing one or more of three things to happen to that patient: hypoxia, hypotension, and hypocarbia. We do not want to let that patient's end tidal get below 35. So keep it between 35 and 45. This is the Galaxy Watch 5 Pro, but I ordered a special watch band that you snap over it to kind of make it look like a what's the big watch that we all used to wear. It's been so long since I used to wear it that I don't even know what it's called anymore. But it's a rugged case around it. G-Shock. If you know that this person is an end title retainer, and you know that this person's normal end title is 55, then maybe you don't want to let it trend much lower than that. But if you don't know anything about this patient, all you can do is just follow normal end title trends. Not every COPD patient is living with higher end tidal levels or CO2 levels. Thanks for all the free education. Your insight is super valuable, and I hope you continue to do this. I will, but I was just talking a little while ago that I might need a break. I've been going for 2 years now. The first year, doing just 1, maybe 2 videos a day, but mostly 1. Getting into the second year, 2 to 3 videos a day, and I'm getting to the point where I get anxious a little bit trying to think of content, and I need to purge my head a little bit of this. So maybe just a 2-3 week break where I don't have to think about this for that long. What's been a positive call patient experience you've had recently? Working with kids, most of my patients actually provide kind of that sort of positive feedback. I tell you what I really, 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 really love is getting to hold babies in anywhere between newborns and a year, getting these sick kids where you pick them up off the stretcher and they just collapse on you and put their arms around you because they're so tired and sick, and so they're comforted by you holding them. Man, I mean, my youngest kid is 24, so I haven't done that, and I don't get to see my grandkids very often because I don't live in the same state as them, and even my youngest grandchild now is not a baby, so I don't get to do that very often. So the positive experience are holding those little babies and having them hold you back. That is the best part of my day. Also, getting to cheer kids up in the back. We have bubbles in the back, and we have stuffed animals we can give out, and the little popping tactile toys that they can play with. And we have iPad with cartoons. And depending on who you're working with, some of us will just start singing to them, together. We'll do Old MacDonald and stuff like that. And getting a patient to start laugh and smile and all sorts of that, to go home and think that today what I did was I sang Old MacDonald to the 17th verse and kept a child from forgetting that his mommy is not back there with him because we don't let parents ride in the back. That's incredibly rewarding. And it's as rewarding as resuscitating an adult from cardiac arrest. Thoughts on pre-hospital heparin administration for STEMI alerts? I haven't looked into that recently. I had thought that there was some data about 10 years ago that came out that it wasn't moving the dial very much, but I haven't looked into it recently. Took Master Your Medics class in Capno, and it's crazy to think how underused Capno is. Capno has very specific applications. Cardiac arrest Capno was great. I know that there's even some services that if their Capno is less than 20, if their end tidal is less than 20, they won't even defibrillate. But you can, watch that trend. You can kind of see how you're doing in CPR. If you see that sudden sharp rise in end tidal, you know that almost the only thing that would have caused that is ROSC. In respiratory, I'd actually find it has diminishing returns. Most of the time, the patient's history and their presentation are going to tell me what they're suffering from. And the Capno isn't telling me much. I don't need to see a sharp fin waveform to know that a patient with emphysema who's wheezing is suffering from bronchoconstriction. I don't need Capno to tell me that an asthma patient is suffering from bronchoconstriction. Now, if their situation is severe then that end tidal is telling me how they're trending. But if I'm just getting an asthma patient that has a little bit of wheezing and you know that you're going to give them a nebulizer and they're going to do better. They ran out of their inhaler yesterday, and you're going to give them a Duoneb and they're going to do just fine. That Capno isn't telling me much, and we don't use Capno in kids very often because the kids do very well as CO2 retainers. Adults don't. Kids don't tolerate hypoxia very well. Adults do tolerate hypoxia fairly well for a time. Adults don't tolerate hypercapnia very well. Kids do. So we hardly ever use that in pediatrics. Where its utility comes in play is these really hemodynamically unstable patients. That Capno tells you a lot. It's a lot more informative sometimes than your heart rate or your blood pressure, because sometimes those changes are very subtle and you won't notice the trend in blood pressure or heart rate, but you'll start seeing that steady change in your end tidal. Non-rebreather mask versus BVM, which one is most effective? In what pathology, may I ask? We get too wrapped up in the negatives. Got to celebrate the wins and the small things. Exactly. Because a non-rebreather is providing FiO2. It is providing oxygen that a person can breathe in. It's not actually high-flow oxygen. That's not considered to be high-flow in any other setting other than EMS. We are the only people that call a non-rebreather high-flow oxygen. It's not high-flow. It doesn't provide any flow. Flow means that it's actually providing a certain amount of force that's working with your own effort to get oxygen into the lower airways. A non-rebreather does not do that. It just provides oxygen that is available to you to inhale. So in lack of any more context, I would need to know in what situation you're looking for a benefit for the non-rebreather or the BVM. A BVM is providing you concentration and positive pressure. So what does the patient need? Also, if you're not aware, when you hook that, if you have a patient that's really suffering and you don't have positive pressure, like CPAP or something like that, non-invasive positive pressure, and that patient is on 15 liters non-rebreather, and they're trying to take that non-rebreather off. Probably the reason for that is because they are exceeding, their demand is exceeding what that non-rebreather is giving them. So you have essentially, it's almost like you just put your hand over their mouth. When a person is breathing, say, 50 times a minute when they're in respiratory distress, they'll often also have increased tidal volumes as well. Their minute ventilation could be somewhere like around 25 to 30 liters per minute. But you're giving them 15 liters a minute non-rebreather, so it's a net loss for them, so they feel like they're suffocating. That flow meter that you have on your wall, which incidentally, the wall of your ambulance, which incidentally is called a Thorpe tube, you'll turn it up and you'll watch that little metal ball go up to 15 liters and then you stop, right? Next time you hook a non-rebreather up to that, just keep going, and you'll realize that you can just keep twisting and twisting and twisting and twisting and twisting, and you can get that up anywhere between 40 to 80 liters per minute. You want to exceed the demand of your patient when it comes to somebody who is experiencing respiratory difficulty. So you have that patient that's struggling, you get them up to a flush rate, that's what that's called, and see how they do. Is BiPAP becoming more prevalent in EMS? I mean, more and more people are getting BiPAP. I would say that CPAP is still on a huge up ramp into EMS as far as like getting into the BLS of things now. BiPAP requires some sort of either BiPAP specific machine or a ventilator, so that ramp up is a little bit slower. We are trialing BiPAP at my service or transfers. I like the way you say that. We're trialing BiPAP. It's like saying we're trialing splints for fractures. So when you look at whether a patient needs CPAP or BiPAP, you have to ask yourself, am I trying to fix an oxygenation issue, or am I trying to fix a ventilation issue, or both? If you are simply trying to fix an oxygenation issue, meaning the patient with their own respiratory effort can get oxygen to the terminal airways, but that oxygen can't cross through the terminal airways, the alveoli. They need CPAP because CPAP fixes oxygenation issues. If your patient is struggling with the ventilatory process, they're not necessarily to the point where they need a ventilator yet, but they're struggling with the ventilation of things, with the accordion in and out process, or the constriction of things, and they need help in the work of getting oxygen to the terminal areas, then they need BiPAP. If they're struggling with getting oxygen to the terminal airways and getting oxygen through the terminal airways, then they need BiPAP. So when you say your service is trialing it, if your patient needs a ventilation fix, they need BiPAP. So hopefully your service is just implementing BiPAP, because that is something that many, many patients need, and just giving them CPAP they'll be fine on CPAP for 10 minutes, well, that could end up being famous last words. We've seen a huge decrease in intubations since being able to use BiPAP pre-hospital. Oh my goodness. And the difference that BiPAP has made and CPAP has made in the treatment of people with pulmonary edema, like CHF patients. Like before, when I got into EMS 20 years ago, like we were just starting to do CPAP. So, a patient who was experiencing, a CHF crisis, or fluid crisis, I mean, they were just going to end up being intubated. And CPAP has made such a huge difference, in preventing people from being intubated, sometimes even preventing them from being admitted. Yeah. Even with the CHF in general, people feel the inspiration, support, and relax so much. Yeah. I mean, there's some people that they just can't get through the panic. But those are, the people who can't get through the panic are the ones that actually really need BiPAP. Give them Ativan. It really depends on your patient presentation. Is your patient experiencing SCAPE, which is sudden crashing or sympathetic crashing acute pulmonary edema? That's essentially a hypertensive crisis where you are so vasoconstricted that it's pushing all your fluid to the core and you experience pulmonary edema. That patient may do very well with an anxiolytic like Ativan, maybe 0.5 or something like that. But if your patient is in CHF crisis, they've been out of their Lasix for a week and now they have peripheral edema and look like they have elephantitis of the legs, and they're like this close to going into cardiogenic shock, probably Ativan is not a good idea for them. Thoughts on the ultrasound fast exam or the EFAST exam for EMS? I don't think that it benefits every service. And in fact, there's a lot of data that says, I don't want to say a lot of data, there's a lot of expert opinion that it provides a very low yield as far as medics doing the EFAST exam in the field. The EFAST exam is a multiple point ultrasound process where you look at several points on the core of the body, looking for free fluid, looking at the left ventricle, that sort of thing. There are services that have demonstrated a benefit of the EFAST exam. I think it's really service dependent, competency dependent. We need more data. We give large doses of opioids for anxiolysis secondary to respiratory distress. That'll work too. But again, you have to, this is going to be patient dependent. There are patients who you just don't want to give them a CNS depressant. You just need them to not have something that's going to be kind of kick that last support out from under the respiratory drive. It's not always the case, but you just want to be sure. There are patients that you look at them and you know, this patient does not need morphine, this patient does not need fentanyl, this patient does not need Ativan. Some of these patients probably would do better with ketamine. Not the ones in sympathetic crashing acute pulmonary edema. They would not do better with ketamine. EFAST yields no purpose unless you're carrying blood, but even then, a patient is most likely reaching your trigger point for transfusions anyway. I think that it has a benefit. I know that a Colorado service published a paper 1 or 2 years ago that demonstrated that that the EFAST exam was making a difference, particularly in the respiratory side of things, in determining. I can't remember off the top of my head, but they were seeing some specific benefits from the EFAST exam, and specifically with lung sliding and with confirming tension pneumos and that sort of stuff. Not confirming, but it was whatever they were finding. It was definitely changing or prompting some treatment to the patient's benefit. But you're right. Without blood, just identifying free fluid in the Morrison pouch. I mean, unless you have an agreement with your hospital that you see that and they're going to have a trauma team waiting, I guess that's okay. But even then, sometimes there just is a little bit of free fluid there. It's not necessarily blood. I think POCUS is mainly beneficial in the cardiac and fluid assessment in undifferentiated shock. It is hugely beneficial in cardiac arrest with somebody who's in PEA, since so many people who are in PEA are actually in pseudo PEA, where they do have some cardiac output. We're just not able to palpate a pulse, either because it's too faint or just because we just aren't. There actually are plenty of people in cardiac arrest who have a pulse that could be palpated, and in the short amount of time that we have, we just aren't finding it. That is a problem in EMS, and that's why we don't do pulse checks anymore. So yes, in cardiac arrest, it has a huge benefit. Badge is here, and he's got a story for me about how the butterfly IQ got inserted into somebody's rectum, I'm assuming. It would be even better if that story had the butterfly IQ ended up getting inserted into a paramedic's rectum and not a patient's. And as soon as I said rectum, a user named BM joined. Swelling at the temples. That is some serious increased intracranial pressure. What is a partial trauma alert? Okay. So like it's, what do they, here they call it tier 1 or tier 2 or whatever or anything like that. I don't have the bandwidth for keeping track of it because you're telling me you're going to have people ready there when I get there? Okay. You work it out on your end. Any tips for passing the EMT registry? Yes. Follow the Bossy Paramedic Girl and go to her channel, her video list. She has playlists with all sorts of tips for people looking to pass the registry. That is, she owns that space here on TikTok, and she does it better than me. But if it's for the EMT, you need to be able to anticipate when you need ALS and that you can't help. You need to know that ALS has to come to you. It's funny, there's this swap that happens for people who are taking these BLS exams. They need to anticipate some of the ALS interventions that this patient is going to need, because they need to know that this is beyond their capabilities. On the paramedic exam, you need to keep in mind that your patient may only need BLS. Like, your ALS exam isn't about everything ALS. It's as much about understanding the building blocks of your treatment and starting with some primary interventions that aren't necessarily ALS. So, hello from a new BLS intrafacility EMT. I love that you're actually bragging about being an intrafacility EMT. I don't know if you're bragging, but I love that you're just waving that flag. I think that's freaking fantastic because it's an important job that you're doing. Any thoughts on PAs becoming field practitioner or medic certified? Bring it on. Bring it on. Somebody has to do this job. Doesn't have to be a paramedic. We just need to get providers to patients in the field. What is my favorite call to run? I like a mystery. I like a medical mystery. I don't like trauma. I find it boring. You know, like a multi-system trauma where the person's all fucked up. I have as much enthusiasm for that as I did for cleaning my room when I was 12. Like, I just don't like being charged with bringing order to chaos. I like getting pieces of a puzzle and trying to solve it. Common mistakes made while administering CPR. Going too fast, not allowing the chest to recoil all the way, not swapping out compressors. That is, all three of those things are the most critical mistakes we make in CPR, and too many pauses. So it used to be that people would be like, the faster the better, and you'd see people do like 150, 200 compressions a minute. If you were to look at a graph at how survival tracks in cardiac arrest, it goes slowly like this. And right here is around 110 compressions a minute. That is the sweet spot right there. Survival is highest at 110 compressions a minute. So you see this gradual upstroke to 110. And then there's this little level off until you get to 120, and then it goes like this. After 120, you just can't create the preload that you need to keep that patient perfusing. So that's your biggest mistake, is going too fast, or one of your biggest mistakes. We had a study recently that actually demonstrated, through the use of measuring pressures within the chest during CPR and measuring relationships to all these pressures to each other, that more so than pushing down on the chest, the way we create our stroke volume is coming off the chest, not just all the way, but really quickly. That's called recoil velocity. And it's one of the most important factors in creating stroke volume and cardiac arrest during compressions, is recoiling quickly. So, and you want to recoil all the way, because if you don't recoil all the way, then you don't perfuse the heart all the way. Remember, when you're pushing down, you're sending blood out to the body and the brain. When you're coming up is when you're sending blood to the heart. So if you don't come up all the way, you're not feeding the heart. And then I said also too many pauses and not swapping out compressors. When you're not swapping out compressors, then you're losing recoil and you're losing recoil velocity, because that's where people sacrifice when they're getting tired. Somebody can be a hero and push down on that chest 2 inches 110 times a minute for 10 minutes straight, but they're going to start leaning on that patient in order to compensate. And so they won't recoil all the way, and they won't recoil as quickly. Rural Medic, 34 years, love your content. Thank you. When do you think EMT is ready for medic school? Is what you're doing right now coming easy to you? Do you understand what you're doing right now? Do the concepts that you've been taught make sense? When people explain things to you, when you ask questions, do you understand what they're saying? When people talk about ALS in front of you, does it make sense? If somebody shows you a new thing and use terms that you've never heard before, after 5 minutes, does it make any sense to you whatsoever? Are people confirming that you're doing really well? Do you have good study habits? If yes to all these things, then you're probably ready now. If you don't understand what you're doing right now, if it's very difficult for you to translate what you've learned into what you're doing, if you need people to explain things to you over and over and over again and you just don't get it, if you passed EMT school by the skin of your teeth and you didn't study and you don't have good study habits, if people are kind of saying, I feel like you're not quite getting this, or or some sort of similar feedback, then no, then you're not ready. Good resource for FPC Medic. There's 3 programs that I recommend regularly, and it really just depends on what you're looking for. So if you want to spend some money for a good program, then the top 2 organizations would be Flightbridge Ed and Impact. I have relationships with both of those companies. When I say relationships, I mean that I know the people there. I have no professional relationship with those companies. I know the people very well there. Some of them I love dearly. So I really don't want to push one over the other, but I will tell you a difference that I have noticed recently between Impact and Flightbridge Ed. Impact has very long modules. Some of them are like an hour and a half long. And I, every year, will take one of these courses just to, learn new things and stay fresh. But when I click on that module and it's like an hour and a half, I'm like, oh, holy God, I don't have time for this. Flightbridge just recently redid their flight course, and their modules are packed into like very bite-sized lengths of anywhere between 5 to 20 minutes. And it's so digestible. It's so easy to go through. And they basically take one concept per individual module and have you focus on that one concept rather than teaching in an hour and a half worth of concepts. So that has a lot going for it right now. But the people that are the teachers are Impact are still incredible teachers, and they do such a good job. Like, I can't speak highly enough of the people at Impact. Those two will set you back a few bucks. If you want to get a class in the budget that's a good class, then MeduPros is good. Charlie Swearingen is on TikTok. He's the Angry Medic. He and I have some stuff going on right now, actually some content we're going to create together with Greg with Shade Tree Cardiology. But he has like $100 course. And, you know, it's a good entry-level course. And, you know, if that's what you have to spend, then you could do that. If you want something that's more comprehensive and guided, you could do something like Creighton University. And that's an actual like college level course. And at one point, I think you do have to fly out there, at least I think for one clinical. But, you know, this is a course that's guided over time and, you know, really does a good job. You know, you can have to spend a few bucks on that too. So it all depends on how much time you have, what your attention span is, and how much money you have. Do you have any link to that study about the recoil and cardiac arrest? Yes, it's in my link tree. I posted it a couple of weeks ago, so you're going to have to scroll a little bit for it. Follow up. Do you obtain the optimal recoil velocity and the ideal depth of the chest without bouncing? I mean, well, you kind of... When you come up from the chest, you need to come up so your palms come off the chest, but not your fingers. That's how you handle doing that perfectly. You don't want to come up all the way off the chest so that you lose your placement and so that you're actually like hitting the chest on the way down. You just want to come up enough so your palms come off the chest, but not your fingers. IAMED is Impact there, KW. They changed their name. Well, they weren't changed their name. IAMED and another company that had a little bit of crossover were purchased by a larger corporate entity, and they were merged into Impact. I am sorry about my glasses too, but they're getting replaced tomorrow. I just passed my national registry test and finally licensed. I'm so excited to get started on the med unit. I'm happy for you. Just letting you guys know that we'll be shutting this down just a couple of minutes. I'm almost at the end of shift, so. How do I feel about epi and sepsis? I mean, norepi would be better. But if all you have is epi, it would be better than dopamine. Medic to RN, sure, that's a great route to take. I think medic to RN is a really good route to go. I wouldn't go through a degree program for medic to do that, but that's a really good route to go. I really enjoy your content, sir. Learn a lot from it. Thank you very much. Do you have any recommendations for BLS transport versus requesting a medic guidelines? I don't, because we don't do that here. So I just not familiar with programs that do that. But I think that more areas should do that, where you send either an EMT or AEMT level crew to a call based on dispatch information and have medics and fly cars. Do I know of any RN to medic programs? No. I mean, the Excelsior program was one that people were taking advantage of for quite a while, but I think it turned out to be kind of a diploma mill. I don't know if it's still in existence. Ever given meds down an eye gel? No, please don't. Please don't put meds in people's tracheas. We have IOs now. So please don't do that. I saw a video about epi for sepsis because vasodilation helps with the low volume and septic shock. What the fuck did you just say to me? So we definitely don't want vasodilation and septic shock. That is the problem in septic shock, is that they are vasodilated. Dilated means that the walls of the vessels have expanded. So a vessel that was like this and creating a really nice blood pressure is now like this, and it's a terrible blood pressure. So that's the reason for the low blood pressure, because there's too much pipe and not enough blood. So we want to make that pipe like this. Make it nice and tight again so we have a good blood pressure, so we can create afterload. Epinephrine causes vessels that are like this to go like this. Yeah, I mean, part of the problem is not enough volume, but in sepsis, the bigger problem is vasoplegia, where our vessels are just too expanded. It is a volume and a diameter problem. So we want fluids and vasoconstrictors, and we don't want to wait on the pressors. If you have a septic patient, you want fluid and pressors. I mean, if they're just barely septic, like they just, I mean, there's some patients you can just give them 250 milliliter aliquots of fluid and they'll do just fine, but have a very low threshold for starting pressors. Anyway, epinephrine counteracts that vasoplegia, that vasodilation, but we would rather have norepinephrine instead of epinephrine if you carry that. But if all you have is epinephrine, that's fine. Can I explain pressors? Yes. So think of your blood vessels as being a muscle. And that's what blood vessels are. They are muscles wrapped around a pipe. And let's pretend that there is a keyboard, like a piano keyboard, on those muscles. And you have those 5 keys, like you would have representing the 5 notes on a keyboard. And they are like labeled, like alpha and beta and dopaminergic and whatever. Specifically, one of those keys, the note that key is called A, or alpha. And the note that it plays is vasoconstriction. And a pressor like epinephrine or norepinephrine or dopamine or phenylephrine or whatever is a finger that goes in there and presses that key on the keyboard and causes that vessel to do a certain thing. And so when epinephrine or norepinephrine or dopamine goes in there and presses that alpha receptor, it causes those muscles to constrict. That's what pressors do. Also remember, though, that you have beta receptors on your blood vessels as well, and that when they are stimulated, they cause vasodilation. But your vessels are much more responsive to alpha stimulation than they are beta stimulation. But you become vasoplegic after too many pressors, and that beta stimulation starts to win. But that's why we would rather have norepinephrine than epinephrine, because epinephrine is agnostic to all of those receptors in there. It targets alpha receptors and it targets beta receptors, which promote vasodilation. Norepinephrine targets specifically alpha receptors and has very low impact. It has some impact, but it has low impact on beta receptors. Does too many pressors cause the opposite effect? I mean, you can have rebound vasodilation from too many pressors. It's more, though, that they're not causing the opposite effect as much as you're becoming vasoplegic, meaning that your vessels are just not responsive to it anymore. Instead of being the world's smartest medic, have you thought about being an average doctor? That's amazing. I answered this question before, actually, but at the age of 55, there's just no return on the investment of going to medical school. Not for me and not for the medical school. And I love what I do. I'm in love with what I do. And, if the resources that I would spend on medical school, I would just much rather spend that on whatever my kids want to pursue. I'm going to cut it off now because we got to go turn in the narcs and shut the shift down and all that sort of stuff. I've been live for like 3 hours. So appreciate all you guys. Thanks for a great live. This is one of the best lives I've had in a while. If you're at work, go out and do good work. Be safe. All the things.